Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget to download the PDF of today's ECG down in the description below so that you can follow along. And subscribe to the channel and like this video if you enjoy this content. So let's jump into it. So let's look at the forest, and trees of the forest are my QRS complexes. And so I look in maybe here at lead 2, and you see I've got this wide complex rhythm, right? So we've got a regular wide complex rhythm. It seems to stay very regular throughout the entirety of the strip. And so I start to form a differential for a wide, complex rhythm. Well, first thing we can do is we can measure the rate of this rhythm. I find a QRS that lands on a solid line, maybe this one. And so I measure 300, 150, 100, 75. We'll say 75 beats per minute, right? So we have a wide, complex rhythm that is not a tachycardia, but it could still be wide, complex. It could be a ventricular rhythm, right? Like maybe it could be AIVR, accelerated idioventricular rhythm. Or 2, it could be some type of bundle branch block, right? Aberrancy, right? Some type of aberrant conduction through the ventricles. And so the first thing I need to do is I need to figure out, well, are there P waves before this QRS? Because we've got a regular rhythm at 75 beats per minute. That kind of gives me some points towards this might be coming from the atria. And if you look closely, you notice that I do see what appears to be P waves in front of my QRSs. If you look, P waves. And in fact, if you look, those P waves, so those are my P waves, there's actually a pacing spike right in front of it. So we've got a pacing spike that occurs, and then a P wave occurs after it. So what does that tell me? That tells me that there is atrial pacing going on. That might explain why this rhythm is so perfectly regular, right? Because every beat has a pacing spike. So what does that tell me? That tells me that we're being paced in the atria, right? So we know that pacemakers, usually, here's my pacemaker box. Pacemakers have 2 wires, typically, if they're dual chamber, which most of them in today's day are. One comes all the way down to the right ventricle, deep into the right ventricle. The other comes all the way over here to, say, the right atria, right? And so right now what we're seeing is the atrial pacing spike is firing off and depolarizing the atria, right? Because it appears that this person is unable to generate their own sinus rhythm that is at least 75 beats per minute. And so this is probably programmed in the atria that if it doesn't sense an atrial beat within the rate that would be 75 beats per minute, then what do we get? We get a spike, and then we get our P wave, right? So we have atrial pacing. So now let's figure out what's happening after the atria is paced. Well, we've got this wide complex rhythm, right? So we have this pacing spike to our QRS complex, but I don't see any pacing spikes before my QRS complex, right? So no pacing of the ventricles. So that tells me that it appears that these QRS complexes are coming from kind of the intrinsic depolarization and propagation of signal from the AV node. And so I can measure my PR interval here from the beginning of the pacing spike to the beginning of the QRS, and you can see my PR interval looks to be 7 millimeters. And so that, if you do the math, that's 280 milliseconds. And I have 1 P wave for every QRS, and so that tells me that we have a first degree AV block, or at least these P waves are being conducted with a first degree AV block to the QRS complex. And so now we need to figure out this wide complex QRS. What is the wide complex? Let's confirm that we think this is being sent to the ventricles via the AV node by finding a bundle branch block pattern. And so I look and I see that I've got in leads 1 and in leads AVL, my lateral leads, I've got this slurred kind of RS, R prime almost, right? We're almost seeing an R prime. We're kind of seeing an R prime here. It's taking a long time to get back down to baseline. That tells me that we have late forces headed from the right towards the left, right? Because we're getting positive late forces, right? This is time on the x-axis. And we know that that normally happens when the left bundle branch is blocked, right? We get signal that's trying to come from the AV node down, but it can't go to the left ventricle or the left bundle branch, and so it goes down the right bundle branch nicely. We get good depolarization of the right bundle branch's territory, and then we get late forces as they travel from gap junction to gap junction all the way through that left ventricle, which is captured in our lateral leads. So I would say that this person has really good criteria for a left bundle branch block, right? And also, we know that the left bundle, if it's blocked, we're going to lose this septal R wave, right? So we have lost our septal R wave, because remember that the left bundle, which is typically right here, is what depolarizes the septum, right? It depolarizes the septum, but it's blocked, so we can't do that. So we lose our septal R waves, right? So more evidence towards this being a left bundle branch block. And so then we go through the rest of our algorithm. We see we have a normal QT interval, right? These T waves terminate at least by the midway point from R to R. We look for pathological Q waves or ST or T wave changes, right? In a left bundle branch scenario, you would use Scarbosa criteria. I'll make a video on that at a later date. And so what do we have? We put this all together. We've got a pacemaker, a dual chamber pacemaker that is atrially pacing, right? And not only do we have atrial pacing, but we have ventricular sensing, meaning that we are pacing the atria, but because that signal is being conducted down into the ventricles, my right ventricular pacing lead does not need to fire, and so it just senses that intrinsic depolarization of the ventricles, and it gets inhibited because we don't need it for that beat. So we have atrial paced, ventricular sensed rhythm being conducted with a first degree AV block with also a left bundle branch block. So good example of a lot of things going on, learning how to work through this rhythm anatomically. That's why I think that the way that I go through these ECGs is helpful for learners who are not trying to memorize algorithms for ECG interpretations, right? I have this generalized approach, but you can always use that and tweak it per the situation based on the anatomy and the electrophysiology. So I hope this video helps. If you have any questions, put them down in the comments, and if not, thanks so much for watching, and see you on the next video. Have a great day.